Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the anatomy of the lung. Lungs are the organs for respiration. They are present in the pleural cavity. We have left lung. This is the left lung. This is right lung. And each lung has an apex. This is the apex of the lung. Okay. So this is the apex of the lung. Base is here. Border, we have the anterior border of the lung, and this is the inferior border of the lung, inferior border, and this is the posterior border of the lung. And surfaces, this is the costal surface, the medial surface. Medial surface has mediastinal part and the posterior or vertebral part. So the apex reaches the root of the neck, and apex has some relationship. We have to know the relationships of the apex. Okay, so apical relationship. So the lungs, apex. The apex reaches the root of the lung. It is around 2.5 centimeter above the medial 1/3 of the clavicle. It is also around 3 to 4 centimeter above the first costal cartilage. Okay, the apex is covered by the cervical pleura. Apex is covered by the cervical pleura, and cervical pleura is covered by the suprapleural membrane. Suprapleural membrane. Okay, we got that. So apex posteriorly related, it is posteriorly in the level of the neck of the first rib. Posteriorly, the apex is related to the neck of the first rib. Okay, so the apex of the lung is reaching the root of the neck, but it is still intrathoracic. We got the apex location. Then we have relations with the apex. Relations of the apex of the lung. Apex of the lung. Posteriorly, it is related to the cervicothoracic ganglion. Cervicothoracic ganglion, also called stellate ganglion. Stellate ganglion. This posteriorly is also related to the ventral rami of first thoracic nerve. Ventral rami of first thoracic nerve. Okay, ventral rami of first thoracic nerve and also superior intercostal artery. This is very important. Cervicothoracic ganglion. It may be compressed in case of apical lung cancer. We call it Bronchus tumor. So the cervicothoracic ganglion may be compromised in Bronchus tumor. Bronchus tumor or apical lung tumor that may lead to Horner syndrome. And we know that Horner syndrome has multiple components like partial ptosis, meiosis, and hydrosis, plus flushing of the side where the Bronchus tumor is located. So these are the relationship to the posterior relationship to the apex of the lung. So it is related laterally to the scalene medius muscle. So laterally they are related to the scalene medius muscle. Anteriorly related to the subclavian artery and scalene anterior muscle. Okay, muscle. So these are the relationship of the apex. Apex is also related to the brachiocephalic vein and also brachiocephalic artery on the right side, left side to the left brachiocephalic vein. Right side, the apex of the lung is also related to the trachea. Okay, we got the relationship of the apex of the lung. Now we'll go to the relationship to the base of the lung. Relations of the base of the lung. Okay. So what is the base? Base is the base of the lung. Base is surrounded by the inferior border of the lung. This is right lung, and the base is related to the right dome of the diaphragm and right lobe of the liver. Okay, so right lung, base of the right lung. The lung is resting on the right dome of the diaphragm. Right dome of the diaphragm. And underneath the right dome of the diaphragm, the right lobe of the liver. Right lobe of the liver. So, right lung base is related to this. How about left lung? Left lung is related to the left dome of the diaphragm, left lobe of the liver, the spleen, and fundus of the stomach. Okay, we got the relationship to the base of the left lung. Okay, now we'll go to the differences between right lung and left lung. This is the left lung. This is the right lung. Left lung is elongated, longer, lighter, and left lung Anterior border of the left lung has cardiac notch, and impression will be different from that of the right lung. When you compare the right lung anterior border has no cardiac notch. It is broader, heavier, shorter than that of the left lung. Left lung has one fissure and two lobes. Left lung has one oblique fissure and two lobes, the upper lobe and the lower lobe. In case of right lung, we have two fissures, the oblique fissure, horizontal fissure, three lobes, upper lobe, middle lobe, lower lobe. So these are the differences between the left lung and the right lung. Okay. Fissure and lobes are variable. We may not have always two fissure, three lobe in the right lung. Left lung may have more than one fissure, may have more than two lobes. That is possible. So we got the differences between the right lung and left lung. Fissures, you have to identify the fissures. This is the oblique fissure of the right lung, and fissure begins around 5 centimeters below the apex of the lung along the posterior border. It cuts the entire lung mass going up to the root of the lung, and it goes to the oblique fissure goes to the inferior border around 6 costal cartilage. This is the horizontal fissure. It is only present in the right lung in most cases. This extends from the anterior border to the oblique fissure. Okay, here in the mid-axillary line. So we got right lung has two fissures, three lobes. Okay, we got that. Left lung, right lung. Okay. Now we'll go to the root and hilum of the lung. Root and hilum of the lung. Okay. Root and hilum. Root means group of structure. Root are group of structures getting in and out of the lung. Okay. Hilum is the space for the root. Okay. Hilum is the space for the root. Okay. We got that. Now we'll find out the structure in the root of the right lung and left lung. Okay. So this structure connects the mediastinal structure to the lung by the roots. Okay. So if we go to the root of the right lung, how they are arranged. Okay, we must find out the structural arrangement. Okay, so if this is the root of the right lung, then we'll get upper part, we'll get the superior lobar bronchus. Superior lobar bronchus. Then we'll get the pulmonary artery. We are looking at the right lung, so it should be right pulmonary artery. Okay. Then superior lobar bronchus. Then we'll get the another bronchus, the main bronchus. This bronchus is for the middle lobe and the lower lobe, main bronchus. Then we'll get the right inferior pulmonary vein, right inferior pulmonary vein. Okay, we got that. We'll get some bronchial artery, we'll get lymph nodes. Okay, hilar lymph node, bronchial artery. We'll get lymphatics, we'll get nerves. Okay, what is present anteriorly? Anteriorly, we'll get the right superior pulmonary vein. Right superior pulmonary vein. Okay, and this entire structure is covered by the mediastinal pleura, and the mediastinal pleura make a sleeve come together the lower part of the lung root and forms the pulmonary ligament. Pulmonary ligament. Okay, and this pulmonary ligament contains some loose areolar tissue, and it acts as a dead space for the dilating blood vessels during physical exercise. We got the structures arrangement in the root of the right lung. Now we'll go to the left lung structural arrangement. Left lung. We have little difference here. Okay. We'll get the pulmonary artery in the top, the left pulmonary artery. Okay. Left pulmonary artery. Then we'll get the bronchus. Main bronchus. You can say left bronchus. Okay. Left side, left bronchus. Okay. Then left inferior pulmonary vein. Anteriorly, you get the left superior pulmonary vein. Okay, we got the arrangement of the structure in the root of the left lung. How about antero-posterior relationship? Arrangement from anterior to posterior in both the lung. Okay, anterior to posterior. Root of the lung on both sides. Anteriorly, superior pulmonary vein. Then pulmonary artery. Then bronchus. Bronchus is usually posteriorly. And in the root of the lung, inferior pulmonary vein is always inferior. Okay, we got the root and hilum of the lung and the relationship. Now we have to find out what structures are present anterior to the root of the lung. Structures anterior to the root of the lung. Okay, we have the anterior pulmonary plexus, anterior pulmonary nerve plexus. We have the phrenic nerve and pericardiaco-phrenic vessels, pericardiaco-phrenic vessels. These are located anterior to the root of the lung. So, structures posterior to the root of the lung, what are those? Posterior to the root of the lung. Okay, these are posterior pulmonary plexus, posterior pulmonary plexus. Then we get the vagus nerve. Okay, these structures are present posterior to the root of the lung. We got the arrangement of structure inside the root, structure in front of the root, structure behind the root. Okay, now go to the arterial supply of the lung. Arterial supply. We have bronchial vessels. We have pulmonary vessels. They have anastomosis to each other. Bronchial vessels associated with nutrition. The right bronchial artery is a branch of the right third posterior intercostal artery. Left bronchial artery, usually two. These are branches of the descending thoracic aorta. Okay. Pulmonary vessels, pulmonary arteries are branches of the pulmonary trunk. Pulmonary veins are coming out of the lung. Each lung has two pulmonary veins. Okay. We got the blood supply of the lung. We go to the lymphatic drainage. Okay. Lung has superficial lymphatic vessels and deep lymphatic vessels. They will go to the intrapulmonary lymph nodes, hilar lymph nodes, then we'll go to the tracheobronchial lymph nodes, bronchomediastinal lymph node, thoracic duct, then right lymphatic duct, then they will go to the veins. So we have superficial lymphatics and deep lymphatics. We have intrapulmonary lymph nodes, intrapulmonary lymph nodes. Okay. Then we have hilar lymph nodes. We have hilar lymph node, also called bronchopulmonary lymph nodes. Bronchopulmonary lymph nodes. Okay. Then we'll get, from there we'll get the tracheobronchial lymph nodes, tracheobronchial lymph nodes. Okay. Then we'll go to the bronchomediastinal lymph nodes. Bronchomediastinal lymph nodes. Then this will go to the either to the thoracic duct or to the right lymphatic duct, and ultimately they will open into the vein. We can call venous angle. This will open into the venous angle at the junction between the interjugular vein and subclavian vein. But the bronchomediastinal lymph node, it may drain directly into the vein or may go through the thoracic ducts. Okay, we got the lymphatic drainage of the lung. Now we'll go to the nerve supply of the lung. Nerve supply. The lungs are internal organ, so it should be innervated by the autonomic nervous system, sympathetic and parasympathetic. These are carried out by the pulmonary plexus, contributed by the sympathetic nerve and parasympathetic nerve, that they enter through the root of through the hilum of the lung, following the bronchi. Okay, so we had nerve supply, sympathetic, usually T2 to T5, for the lateral gray horn of the spinal cord, T2 to T5. Okay, parasympathetic, that is carried out by the vagus nerve. Okay, sympathetic, they are bronchodilator, and they decrease the secretion. Vagus is bronchoconstrictor, parasympathetic, bronchoconstrictor, okay, bronchoconstrictor, and it is secretomotor to secrete inside the bronchus. So for asthmatic patient, usually the patient get the aminophylline, salbutamol, ventolin, albuterol. These are sympathomimetic drugs, even epinephrine. Okay, we got the nerve supply of the lung. Now we'll go to the bronchial tree. Bronchial tree is important to us. So the bronchial tree. Okay. So if you go from the trachea, then we'll get the primary bronchus or main bronchus, then secondary bronchus, or also called the lobar bronchus. Then we'll go to the tertiary bronchus, also called segmental bronchus. Okay. So this division will continue, nearly 15 to 17 division. Then we'll get the terminal, then we'll get the bronchiole, then terminal bronchiole, then we'll get the respiratory bronchiole, alveolar duct, and we'll get eventually the alveoli. Okay. So each primary bronchus for each lung, secondary bronchus for the lobes. Right lung has 2 fissures and 3 lobes. So the right lung has 3 secondary bronchus. Left lung has 1 fissure, 2 lobes. So left lung has 2 secondary bronchus. So each lobe will be divided into segments to get the tertiary bronchus. Okay. So each tertiary bronchus will forms a sector. We call it bronchopulmonary segment. Bronchopulmonary segment. Okay. It contains a tertiary or segmental bronchus. Okay. It contains pulmonary artery branch. It contains branch of pulmonary artery and bronchial vessels. Okay. Inside the bronchopulmonary segment. Okay, so if this is the bronchopulmonary segment, apex is directed towards the root, and we'll get a tertiary bronchus like this. We'll get branch of pulmonary artery like this. Bronchial artery will get there. Okay, but in between the bronchopulmonary segment, we have some connective tissue that is the site for tributary of pulmonary vein. Tributary of pulmonary vein. So the tributary of the pulmonary vein is not inside the bronchopulmonary segment. It is in between the bronchopulmonary segment in the connective tissue septum. Okay. Bronchopulmonary segments are important because a surgeon may take out 1 or 2 bronchopulmonary segments without disturbing other bronchopulmonary segments. Surgeon goes through the connective tissue septum between the bronchopulmonary segments, especially they manage the emphysema or lung abscess case, even small tumor. They may take 2-3 bronchopulmonary segments without disturbing the functions of the entire lung. But it may not be confined to 2-3 segments of the bronchopulmonary segment. In case of tuberculosis, it may be diffuse. So it depends on the pathology. Okay. So we got the bronchopulmonary segment. How many bronchopulmonary segments in the right lung and left lung? Usually we should have 10 bronchopulmonary segments. Bronchopulmonary segments. Okay. 10 bronchopulmonary segment in the right lung. Left lung usually has 8 or 9 bronchopulmonary segment because 1 or 2 bronchopulmonary segment may be fused together. So if we go to the right lung, from the upper lobe, we'll get the apical, anterior and posterior bronchopulmonary segments. Right lung middle lobe will have lateral bronchopulmonary segment, medial bronchopulmonary segment. Right lobe, lower lobe. Right lung lower lobe, we have the superior bronchopulmonary segment anterior basal bronchopulmonary segment, posterior basal bronchopulmonary segment, medial basal bronchopulmonary segment, lateral basal bronchopulmonary segments. So here 5, here 2, here 3. These are the bronchopulmonary segment. Middle lobe has 2 bronchopulmonary segment, upper lobe has 3 bronchopulmonary segment, lower lobe has 5 bronchopulmonary segment. But in case of left lung, we may have 8 bronchopulmonary segment. These two may fuse together. These two may fuse together. These two may fuse together. So bronchopulmonary segment may not be 10 in both sides. Usually right side has 10 bronchopulmonary segment. Left side has 8 bronchopulmonary segments. Okay, we got the bronchopulmonary segments. Before going to the next part, we have to know that our division of the bronchi, these are dichotomous fashion, 1 going to be 2, 2 going to be 4. So there are nearly 25 to 27 divisions are taking place up to puberty. Okay, so and our bronchi both sides are not same size. Right bronchus is vertical, left bronchus is more horizontal. So this is right bronchus, right main bronchus, or right principal bronchus. Okay, this is vertical and it is shorter. This is the left main bronchus, left main bronchus. This is horizontal. This is more or less horizontal, less vertical. It is longer, it is narrower than that of the right side. So we have more infection on the right side because here more foreign body infection, more infection is on the right side due to the more wide and short right main bronchus. Okay, we got the bronchopulmonary segment. Okay, now we go to the development of the lung. Okay, before going to the development of the lung, we have to know that the histology little bit. Histology, especially the lining epithelium in the trachea, lining epithelium, trachea, and the bronchus, major bronchus, the primary, secondary, tertiary bronchus. Our epithelium is pseudo-stratified ciliated columnar epithelium, and they contain also cartilage, hyaline cartilage. Certainly we have hyaline cartilage. Okay, if you go to the bronchiole after many divisions, nearly 10 to 15 division, bronchiole 1 millimeter diameter, 1 millimeter diameter. Okay, and bronchiole has no cartilage. Epithelium will be low columnar. Okay, we will get the terminal bronchiole. Here, no cartilage, and we will get cuboidal. Gradually, height is decreasing. Cuboidal epithelium, Okay, low columnar epithelium. Then we'll go to you'll also get here some cell called Clara cells that will protect our respiratory passage. There's some antioxidant action. Also, they may produce part of the surfactant, may contribute in the epithelialization of the bronchiole. Then we'll get the respiratory bronchiole. Okay, we'll get epithelium, cuboidal. Okay, cilia will go down gradually. You may not get any cilia at this level, maybe very minimum cilia. Then in the alveoli, last part, alveoli, lining epithelium is simple squamous. Simple squamous. Here we have two types of epithelium. Type 1 is simple squamous. Type 2, alveolar epithelium, are cuboidal. We call it type 2. They produce surfactant. Without surfactant, especially in premature baby born from the diabetic mom, they may have neonatal respiratory distress syndrome. Okay, so surfactant is a phospholipid released by the lung alveoli. We have simple squamous epithelium. Some of them are cuboidal. They release the surfactant that protect our respiratory passage, decreases surface tension, and prevent respiratory distress syndrome of the newborn. Okay, we got the histology of the respiratory system. Now I will touch something about the embryology. Lungs are developed as a foregut diverticulum, as lung bud. A foregut diverticulum around 4th week of intrauterine life. Okay. Then lung bud will continue to divide, make to bronchi, then secondary bronchi, tertiary bronchi. It will continue to divide, and the lining epithelium and glands are endodermal. Cartilage, muscles, connective tissue are mesodermal. Okay, and lung has different stages of development. It has multiple stages of development. So it has stages of development like pseudoglandular period, then canalicular period, okay, terminal sac period, Then alveolar period. This happens after 28 weeks of gestation. So around 28 week alveolar period begins. So baby may born at that time even prematurely can survive. During this period, very small fetus, so it will not survive. They will not cause gaseous exchange. This will cause gaseous exchange. Okay. So development may not be always sound. We may have anomalies. Regarding fissure, always there is some variation, but most common and disturbing anomaly is the tracheoesophageal fistula. Esophageal fistula. This may happen due to the septum separating the respiratory passage from that of the GI passage may not be developed properly, so that may happen. So we may have that problem. So we got the lung, little bit embryology. Now look inside the lung. Okay, so again, if I go there, sorry for that. Okay, this is the anterior border, posterior border, mediastinal surface. That surface is important to us. Okay, this is the right lung. So mediastinal surface is related to the heart here, cardiac impression for the inferior vena cava, impression for